Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by our senior colleague, Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here, we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of Nath Arua and the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very handy in your line of duty. I now welcome you all to part 399 of our pharmacotherapy series, which majors in upper gastrointestinal disorders. This part of the series discusses patient TAD from part 398. What is the concern regarding the use of COX-2 inhibitors, and the risk for cardiovascular toxicity? The risk for cardiovascular events in patients taking COX-2 inhibitors increases with a number of factors, including increased COX-2 selectivity, higher dosages, a longer duration of treatment, and pre-existing cardiovascular risk. Although ulcers and related gastrointestinal complications were less likely with rofecoxib than with naproxen in the VIGOR trial, the number of myocardial infarctions and thrombotic strokes were increased with rofecoxib. Similar cardiothrombotic events were observed in other rofecoxib studies of longer duration. In 2004, rofecoxib was withdrawn from the U.S. market, and soon thereafter valdecoxib was withdrawn amid concerns about cardiovascular risk. The cardiovascular safety of celecoxib has been evaluated, but the risk of myocardial infarction and thrombotic stroke is less certain. Although there was no difference in cardiovascular events when celecoxib was compared with diclofenac and ibuprofen in the CLASS trial, cardiovascular events were significantly higher in a clinical trial where patients were taking higher dosages of celecoxib, i.e. dosed at 400 mg twice daily. Celecoxib remains available in the United States, but the underlying cardiovascular risk of the patient must be assessed when considering the use of this drug. The lowest effective celecoxib dose should always be used for the shortest duration of time. The risk for cardiovascular events is also increased in patients taking non-selective and partially selective non-steroidal anti-inflammatory drugs, with the possible exception of naproxen. Naproxen is usually the preferred non-steroidal anti-inflammatory drug, especially in patients with increased cardiovascular risk. If possible, non-steroidal anti-inflammatory drugs and COX-2 inhibitors should be avoided in patients at very high gastrointestinal and cardiovascular risk. Consideration should be given to using less risky therapeutic options, including acetaminophen, tramadol, or narcotics. Thus, the selection of a drug regimen to reduce the risk of non-steroidal anti-inflammatory drug ulcers and gastrointestinal complications should not only be based on the gastrointestinal safety of the non-steroidal anti-inflammatory drug or COX-2 inhibitor, but must be weighed against the cardiovascular risk for each patient. My next question to you reads: How does a COX-2 inhibitor compare with a proton pump inhibitor and a non-selective or partially selective non-steroidal anti-inflammatory drug when used to decrease ulcer risk and related complications? Have any studies evaluated gastrointestinal safety in patients taking a COX-2 inhibitor plus a proton pump inhibitor? There have very few randomized controlled trials in Helicobacter pylori negative patients at high risk for non-steroidal anti-inflammatory drug-related complications that compared the combined therapy of celecoxib with a proton pump inhibitor versus a partially selective non-steroidal anti-inflammatory drug with a proton pump inhibitor or celecoxib alone. Results from these trials suggest that in high-risk Helicobacter pylori negative patients, combined therapy with a COX-2 inhibitor and proton pump inhibitor may be more efficacious than a partially selective non-steroidal anti-inflammatory drug plus a proton pump inhibitor or celecoxib monotherapy in reducing non-steroidal anti-inflammatory drug-related ulcer complications. Combining a COX-2 inhibitor with a proton pump inhibitor may be considered in very high-risk patients. However, long-term outcomes are unclear given the longest clinical trial follow-up was 1 year. The next question reads, what factors should be considered when evaluating management strategies for patients at risk of experiencing a non-steroidal anti-inflammatory drug-induced ulcer? What risk reduction strategies are considered acceptable for TAD? Strategies to reduce the risk of non-steroidal anti-inflammatory drug ulcers and related complications depend on the assessment of upper gastrointestinal and cardiovascular risks. Although there are no universally accepted definitions, the levels of risk can be arbitrarily stratified into low, moderate, and high gastrointestinal risk and low or high cardiovascular risk. High cardiovascular risk implies a physician-recommended requirement for low-dose aspirin to prevent serious cardiothrombotic events. In general, individuals younger than 65 years, and those taking non-steroidal anti-inflammatory drugs in the short term who do not require low-dose aspirin, are considered to be at low gastrointestinal and cardiovascular risk and usually do not require gastrointestinal risk reduction therapy. Patients at moderate gastrointestinal risk typically have 1 to 2 risk factors that include age older than 65 years, a history of a prior uncomplicated ulcer, treatment with high-dose non-steroidal anti-inflammatory drugs, or the concurrent use of aspirin, including low-dose, corticosteroids, or anticoagulants. The recommended risk reduction strategy in this group is co-therapy with either a proton pump inhibitor or misoprostol, but misoprostol is usually considered a secondary option because of gastrointestinal adverse events and the need for more frequent daily dosing. If the patient requires low-dose aspirin, naproxen is the non-steroidal anti-inflammatory drug of choice. Although a COX-2 inhibitor provides similar gastroprotective effects as a non-selective or partially selective non-steroidal anti-inflammatory drug plus a proton pump inhibitor or misoprostol, the use of COX-2 inhibitors, including celecoxib, has declined dramatically because they are typically more costly than the non-steroidal anti-inflammatory drug plus proton pump inhibitor, and because of concerns related to myocardial infarction and thrombotic events. Patients at very high gastrointestinal risk include those with a prior history of an ulcer-related complication or multiple, that is greater than 2, risk factors. If cardiovascular risk is low, alternative therapies such as oxycodone are preferred, but a COX-2 inhibitor plus a proton pump inhibitor or misoprostol may be used. Although it is best to avoid a non-steroidal anti-inflammatory drug if the patient had a complicated ulcer, some physicians will continue the same non-steroidal anti-inflammatory drug that provided the most effective anti-inflammatory effect. This should be done with extreme caution and with maximally effective co-therapy. Non-steroidal anti-inflammatory drugs and COX inhibitors should be avoided in patients at high gastrointestinal risk and high cardiovascular risk, and alternative therapy should be used. Patients like TAD, who have a history of a recent ulcer and related upper gastrointestinal bleed, are at high risk for future non-steroidal anti-inflammatory drug-related ulcers and complications and require an effective risk reduction strategy. Additionally, TAD has other factors that contribute to her high-risk status, including her age, that is 70 years, and the continued use of a non-selective non-steroidal anti-inflammatory drug, e.g. naproxen. Ranitidine should be discontinued immediately, and TAD should be switched to an evidence-based risk reduction regimen. If celecoxib is used, the risk of cardiovascular effects must be weighed against the gastroprotective benefits, especially because TAD has a history of hypertension. If TAD had renal dysfunction, creatinine clearance below 30 ml per minute, non-steroidal anti-inflammatory drugs and COX-2 inhibitors should be avoided, and the patient should be treated with other analgesics, e.g., tramadol, narcotics, keeping in mind that non-steroidal anti-inflammatory drugs and COX-2 inhibitors are associated with fluid retention, hypertension, and renal failure. Although switching naproxen to celecoxib plus a proton pump inhibitor or continuing the oxycodone may be preferred by some, the selection of the optimal strategy for a high-risk patient like TAD is debatable and should take into consideration the risks, benefits, patient preferences, continued analgesic relief, and cost of treatment. Co-therapy with a proton pump inhibitor or misoprostol is an acceptable risk reduction strategy given TAD's gastrointestinal and cardiovascular risk. Combination therapy of celecoxib and proton pump inhibitor may represent the greatest gastrointestinal risk reduction and may be considered in this patient. The next question reads: what information should be conveyed to TAD regarding the combined use of over-the-counter aspirin and non-steroidal anti-inflammatory drugs? Remind TAD that her physician has recommended that she discontinue taking the enteric-coated aspirin and that she should not restart it without his or her consent. Explain to TAD that enteric-coated aspirin may protect against the topical mucosal damage in the stomach and minimize dyspepsia, but the enteric coating does not prevent an ulcer. Even low-dose aspirin, e.g., 81 mg per day, is capable of causing an ulcer, especially when used in conjunction with a non-steroidal anti-inflammatory drug, e.g. naproxen. Buffered aspirin may cause less dyspepsia, but buffering does not prevent ulcers. Taking food, milk, or an antacid with aspirin or non-steroidal anti-inflammatory drugs may minimize dyspepsia but does not prevent an ulcer. Inform TAD that she should not take over-the-counter non-steroidal anti-inflammatory drugs in conjunction with her naproxen unless advised to do so by her physician, because combining non-steroidal anti-inflammatory drugs will increase the risk for ulcers and gastrointestinal bleeding. Advise TAD that even though non-steroidal anti-inflammatory drugs available for self-treatment may have different generic names, e.g., ibuprofen, or naproxen, or brand names, e.g., Advil, or Aleve, they all belong to the same drug class and have similar side effects. TAD's physician decides to maintain her on naproxen but changes the famotidine to lansoprazole 30 mg daily. So my question to you reads: what instructions should you provide TAD regarding her medications? TAD should be advised of the major signs and symptoms of upper gastrointestinal bleeding and cardiovascular disease and what action should be taken if these signs or symptoms develop. She should be instructed to take the lansoprazole daily 30 to 60 minutes before breakfast and continue taking naproxen twice daily. The importance of adhering to proton pump inhibitor co-therapy must be stressed, especially because TAD may not have accompanying dyspeptic or ulcer-like symptoms. There is a strong relationship between the level of adherence to gastroprotective medication and the risk for ulcers and serious gastrointestinal complications in patients like TAD who are high-risk non-steroidal anti-inflammatory drug users. Older patients, like TAD, who are at risk for osteoporosis and hip fractures and who require long-term proton pump inhibitor therapy should be counseled to take age-related recommended dosages of a calcium salt and vitamin D and have periodic bone density examinations. The next question reads: what parameters should be monitored to determine TAD's response to treatment? High-risk patients like TAD who continues to take a non-steroidal anti-inflammatory drug should be closely monitored for upper abdominal pain and signs or symptoms associated with bleeding, obstruction, or perforation. The presence of upper abdominal pain or a change in the severity of the pain may suggest an upper gastrointestinal complication. Every effort should be made to monitor TAD's compliance to her proton pump inhibitor regimen because of the strong relationship between non-adherence and the risk of upper gastrointestinal complications in high-risk non-steroidal anti-inflammatory drug users. So there you have it. Our highly esteemed viewers and listeners, that brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. On behalf of our senior colleague, Dr. Nath Arora, I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 400.